Hello, everybody. Recording live from somewhere. This is Zach Couples with episode number 24 of the Movement Debrief. And we got a new one, even though it's a different time. It's still the same ill shit. Here's what we're talking about today. We're going to talk about knee pain, and we're going to talk about modalities. What is my stance on those things? What do I feel about them? All that kind of stuff. But before that, some housekeeping. Did you guys see my blog this past week? What was it? Well, I'm glad you asked. It was the links. It was everything that I've come across in the month of October. I'm losing it, man, because this November thing's going by way fast. But anyways, it was all the links that I came across in October. If you're interested in getting those on a weekly basis, which is a little bit more digestible, and then you can brag to all your peeps, hey, did you read this article? And they'll say, well, no, I've been waiting a month for Zach to release them. Nah, you can get them ahead of time. Go to zachcouples.com, sign up for the newsletter, and you can get those and brag to everyone. Otherwise, my course that I'm going to be teaching, my 2-day seminar, Seattle, Washington, September 16th and 17th, I believe, are the dates. Let me just double check that right quick. But of next September, all right? There's a name for the class, guys. Are you ready for the name? I don't know if you're ready for the name. Because, first off, I'm sorry. It's the 15th and 16th of September next year. I don't know if you're ready for the name. But I have to give kudos to Lucy Hendricks of Enhancing Life for inspiring this name. But it's called the Human Matrix. Whoa. The code for maximal health and performance. You guys should check it out. I hope to see you there in Seattle. It's going to be cool. If you are like part of this little doodad that I'm doing, please let me know. Let me know you like or you hate what I put out, and we'll go get some food or something, man. So please come to the class. Other than that, I think that's all I got for housekeeping, guys. So let's debrief, shall we? 2 questions today. The first one comes from Jordan, and Jordan asks, "Hey Zach, what do you do for knee pain?" I think you specifically said patellofemoral pain, but let's just go a little bit broader and let's talk about knee pain. That's a phenomenal question, Jordan. And I've been getting a lot of questions like this that deal with condition A, condition B, condition C, condition D. And really the process is pretty much the same for all of these things. The knee is a little bit different because I think there's some things that you can do locally that are impactful. But let's unpack that, and that's why I wanted to discuss this. So, very first thing, are they meant to be in your clinic? Are you cool to work with them? Are you someone who can help them? Do your differential diagnosis, make sure that there's nothing structural that cannot or that requires intervention from someone else. So ACL tears, although interesting tidbit on ACL tears, there's this guy, oh gosh, his name's escaping me, but I will put it in the show notes, but he spoke in the land of China. Let me write that down. I'm going to put his name down because he had a really good talk, actually. ACL guy. Okay. In terms of the ACL, I asked him because he did a lot of research on post-surgical ACLs and why these guys are getting arthritis after an ACL surgery. And he said the big thing was a lack of loading the cartilage, so which was kind of interesting to me. And so I asked him, I said, hey, if let's say you had an ACL tear, what graft would you get? And his answer blew my mind because he said, I wouldn't. And I was like, whoa, because, there's always this great debate. Do you go patellar tendon? Do you go hamstring? Do you go with allograft? Do you go with a synthetic? And he said none. And that just really blew my mind. And I wonder if that was, I didn't get a chance to have him dive into that a bit more. But we do know that there is a certain portion of the population that can cope without an ACL. And we also know, based on some of the variability research, that those individuals who do not have an ACL seem to have reduced variability, and those who get the graft seem to have an excessive amount of variability. And perhaps the tail end of that curve is less desirable than being a little bit more rigid, because it requires much more control and coordination when you have excessive variability. So I don't know. I mean, I just thought it was an interesting tidbit. So maybe even an ACL tear is something we need to be trying to go the conservative route first. But I don't know the answer. I haven't seen anyone who's gone that route personally. Most people seem to get grafts, but that's a little side tangent. First thing, are they appropriate for you? Once you've determined that, then the process is the same, man. You treat the axial skeleton, see what that gets you, because we know that hip position and hip strength, hip function, hip motor control has an impact on what goes on in the knee. So I will address the snot out of that. Proximal orientation. So I'm making sure my people have normalized infrasternal angles. I'm making sure they can achieve a zone of apposition. Making sure hip mobility is restored in all planes. And I am getting variability till the cows come home. And of course I'm going with sagittal plane first, then frontal, then transverse. And in terms of sagittal plane in particular, I think, especially if you got like anterior knee pain, hamstrings are kind of a big deal for a lot of people. And I think they're also a big deal for people who are lacking an ACL, because the hamstring is the ligamentous muscle for the ACL. It's the only real thing that's going to check anterior tibial translation in absence of an ACL. And I have a real life example of that, because I had a patient this week who I'm seeing pre-op, and she's got a limitation in knee extension. She had a limitation in knee flexion, and we got to restore knee motion before she gets into surgery 1. We have to get her as physically prepared as possible to go through that process. And guess what I did to restore knee extension? Got her a hamstring. Why? Because the reduction in knee extension, maybe at least this is how I'm rationalizing it biomechanically, is potentially some type of protective mechanism to limit anterior tibial translation, since there is a deficiency in the ACL. And so if you give some type of sensory cue, i.e. hamstring contraction, to allow for the reduction in excessive anterior tibial translation, you can get a restoration of knee extension. And when I got her hamstring, she had full active contraction, but she had full passive knee extension afterwards, and she had almost near full flexion. So it was pretty cool to see. So get the hamstrings. That's really important. When you are also working sagittal plane, I think that is a prime time for these individuals who have anterior knee pain to start teaching deadlifting patterning, which is, again, reinforcing hamstring, reducing anterior tibial translation, many good things. I also think during this time frame it's very important to teach people to squat. And I don't want none of this vertical tibia bullshit when you're squatting, fam. Push the knees forward. If you can, keep your heels on the ground. Push the knees forward. Get a little bit of a posterior pelvic tilt. That's going to put the knee in a very, very safe position. You're going to minimize shearing. Why? Because the hamstrings, again and again, coming for the win. Those limit anterior tibial translation, which is probably more the problematic issue biomechanically with individuals who get that excessive shearing. So don't be afraid to squat during the sagittal plane phase. Make sure you're teaching people to push their knees forward, change levels, get a good co-contraction of quads and glutes. So that's kind of the sagittal aspect. Obviously, frontal plane, I think, frontal and transverse plane are very important because you want to restore hip range of motion in multiple directions. Because if you don't have it, something has to pick up the slack. And if we think anterior knee pain as an example, in my opinion, I think it's the quads that pick up the slack. Because the quads do have a slight degree of a moment of rotational capabilities at the hip. It's very, very slight. And you won't see that in an anatomical textbook. You'll see that more in a patterned type of course or something along those lines, and postural restoration comes to mind because they're the ones who taught me that. Let me write down that course because that's important. You want to take impingement and instability. That's going to go in the show notes. But when I have reductions in hip range of motion, the quads have, based on the position that the knee goes into, the vastus lateralis can pick up a little bit of leverage as an internal rotator. And you can't visualize that in normal anatomical conditions. You have to visualize it in compensatory anatomical conditions. And basically just is oriented in such a manner that the greater trochanter is pushed a little bit more forward. The angle of pull on the quads is different. And so that could potentially lead to increased quadriceps activity because the quads do two jobs. One, it's stabilizing the knee joint. Two, it's trying to create a little bit of motion at the hip. You get a quad that's overworking. Maybe you get some issues going on at the knee joint itself. Restore hip range of motion. Quad function is normalized. Life is good. Now, sometimes after you've done all that, you've restored mobility at the hips and you've restored variability, and maybe you've even taught your peeps how to control and coordinate at very high levels. So thinking a 5 out of 5 on the active mid-stance test, which I'll link in the show notes, 15s on the Copenhagen, but they still have knee pain. What do you do there? I'm glad you asked. So with that, you have to look locally. And I have to credit Bill Hartman for kind of inspiring this for me, because that was one thing that I was kind of doing, but maybe I wasn't as laser-like as I ought to be. Because sometimes what you'll see is some funky things going on at the femur versus at the tibia. And probably the most common one that I see, and this is on right knee pain in particular, is the femur is in a position of internal rotation and the tibia is relatively externally rotated. If you want an example of this, come to my next family reunion, because literally everyone in my family has this. It's absolutely remarkable, and I'm included. So if you watch me walk around, you'll see it. So when you see that, you got the femur going one direction, you got the tibia going another. Problems, fam. You got a little bit of twist through the knee joint. That could potentially be nociceptive. So what do you do for that? If you've cleared everything else, the simple fix is to untwist them, at least the way that I think of it. And so if I have a femur that's going in the IARD position, I have a tibia that's going in the EARD position, I do the exact opposite. So on the right side, I'll internally rotate the tibia by finding and feeling my arch on that side. And then while maintaining the arch, I will externally rotate the femur to give me a glute max. And theoretically, that derotates the knee joint. That's just the way that I think about that in simple terms, as whatever directions the tibia and the femur are going, if they're opposite, bring them together. And so if you had an example where the femur was externally rotated and the tibia was internally rotated, well, you probably put a little bit more of your weight on the lateral aspect of the heel, and you might drive IR of the femur in a hip shifted position. So you go after the adductor magnus and those types of things. So just think about detwisting. That concept's been very, very big for me. How do I assess for that? I don't have a great assessment aside from checking hip range of motion. You can check tibial external and internal, but a lot of times you just can see it visually. Now I'm probably the last person to trust my eyes, but I think one thing after, again, discussions with Bill and just seeing more people with knee pain is because a lot of times we don't have good tests, especially when we've restored all these things, and maybe power and capacity improvement isn't doing it. Maybe there is a role for default posturing. So I know everyone thinks, oh, static posture, blah, blah, blah. It doesn't cause pain, so on and so forth. Maybe not in some individuals. Maybe it does in others. But it gives you information about what do these people do under normal resting conditions, or what is their body trying to do to help them maintain gravity when stress or threat is low. And I think that's probably one thing I'm going to be spending a bit more time on this upcoming year, is just improving my eye for that and my knack for that. And I think the knee joint is probably a great place to start with that. So, if you see a patella oriented one direction and you see the tibia or the foot going way the other direction, trust your eyes, see if you can derotate them, and you'll probably be in business for knee pain. So that would be how I would address variability, and in most individuals, that's what I do for knee pain. Now, if I have someone who is still struggling at higher intensities or longer durations, then we're looking at building power and capacity, and really all that is that's the easy part, guys. That's just progressively loading them. So teaching them good squat mechanics under load, teaching them deadlifts, teaching them split squats, single leg squats, RDL variations, all that stuff. Like, all of that's important. Jumping, incredibly important. Being able to effectively jump, bound, hop, all of those things is extremely important for me when I'm bringing someone back from in a return to play kind of, or not even return to play, but just a return from injury paradigm, because I think any type of plyometric activity is a great way to load the lower extremities, helps build the power, great way to increase force production, great way to test how well they can control and coordinate high intense scenarios. So I also think for people with knee pain, you have to get them effectively jumping and working on their landing mechanics. So that's really all I got for knee pain, I think. Yeah, that's about all I got, guys. So to summarize, make sure they're appropriate, restore variability, hips, everything, guys. If there's still problems, look local. And typically the local fix is to get them in a relatively neutral position. So if their femur and their tibia are going opposite directions, bring it together, fam. Give them some love. And then once you've done that, build power, build capacity, get them out of your clinic. So thanks again for the wonderful question, Jordan. Next. This is from John. Hey, Zach, is there a place for modalities in rehabilitation? John? Yes. There's a time and a place for modalities in rehabilitation, and it's the same time and place as there is a time and place for decaffeinated coffee. And the answer is never and in the trash. Just kidding. But not really. Anyways, so modalities. This is a good question. So let me just put my biases in the mix. When I went to PT school, we had a modalities class, obviously, and I had musculoskeletal professors who were very good manual therapists, and they were very anti-modality, and so that was already kind of burned into my brain very early on. Then I did an internship with Daddy-O Pops Bill Hartman, and he was very anti-modality, and I've kind of stayed on that pathway since. And it's not for me not looking into that stuff, because I've done some research in a few of the modalities, and ultrasound, of course, I mean, there's nothing out there, guys, except for the joke study that Adrian Lau did in terms of determining if clockwise ultrasound for pain is helpful, which it is, surprisingly. So I'll put that in the show notes. It's a pretty interesting study. But in terms of symptom management, and I'm just thinking about like all the modalities that I would potentially use. there's only probably a few scenarios in which I think it's warranted. E-stim would be one of them, and there's 2 times that I would use E-stim. One, there's a little bit of evidence showing that interferential current could potentially reduce swelling. And that's big for me because I have tried to scour the internet to some degree, and you don't find much of anything that seems to improve swelling from a rehabilitation standpoint. But for some reason, IFC seems to be helpful. So that's one thing I've used, for sure, is I've done E-stim to help mitigate swelling to a degree. How much? Who knows, right? So that's one time I would use E-stim. Another time would be in combination with blood flow restriction retraining. There's an article, and I can link that in the show notes. BFR plus E-stim. And I'll link the swelling one if I can find that. But there was an article done on Jesse Owens' website, Owens Recovery Science, and they talked about combining BFR and E-stim. And so this goes actually back to our knee pain example. But it seems that, yes, NYGXO, Russian stim post-op. I do that with blood flow restriction training. So I'll do that type of E-stim, either Russian, or I'll do just regular good old-fashioned contracting E-stim to see if we can get a quad to fire. I mean, I use Russian, and then occlusion training is what I use in NYGXO. So basically what I'll do is I'll do the BFR protocol. Oh, Gerard, what's up, fam? How you living? Man, this guy's got a gang of questions, man. Okay. Now I know. NYGXO, you are no longer that, but you are Gerard. And I'm living the dream, my guy. How are you doing today? So in terms of your mentioning of Russian, yes, I'll use Russian in combination with blood flow restriction. So what I do is hook them up to the cuffs, hook up the E-stim, and I have them rep out 30 reps, try to time it in such a manner that maybe it's like a 3-second ramp for the contraction, and then it's relaxed, and you just keep doing that over and over and over again. And, I use the BFR protocol, which is 1 set of 30 and then 3 sets of 15. And that seemed to actually do quite a good job of restoring some quadricep size in people, since we know that arthrogenic inhibition is a thing. And it seems to restore strength to some degree. So I think like those would be the 2 instances in which I would use E-stim. Another instance, even though it's not like the traditional E-stim, that I will do some type of electrical kind of thing is with dry needling. And that was something that I picked up from the Spinal Manipulation Institute, or the Dry Needling Institute, when I took their courses. And what they recommend is you get kind of like double the effect of needling when you hook it up to electricity. And so you have them hashtag ride the lightning, and you do that anywhere from like 8 to 30 minutes. I think they recommended 20. Sometimes I will do that as well. The problem with all of those things, and with most modalities in general, and it's probably the reason why I don't use them that much, is because it's so damn time consuming. And for me, from a principle standpoint, exercise is so much more important. And I can't sacrifice that unless I absolutely have to. And I can a lot of times get the same changes with a manual intervention much faster. I do a few passes of pin and stretch, and a lot of times that can relieve symptoms. So it's like, why should I do a modality for 8 minutes so I can get billed? It just doesn't seem to make time sense for me, especially when time is becoming more and more precious as a physical therapist. In terms of other modalities, I'm just trying to think. I've been known to occasionally dabble with, what's this stuff called? It's anti-inflammatory. Put the patch on. Oh my gosh, isn't that terrible? That shows how often I use it. Iontophoresis. Thank you. I believe there's a little bit of evidence to support using iontophoresis, but again, it's a time thing. The ones that I did use were the 14-hour patches because I sure as hell wasn't going to waste 5-10 minutes or whatever doing them in the clinic, and those seem to be pretty effective for some people if you have some type of peripheral sensitization, which if you check out Lorimer Moseley, you can find out if someone is peripherally or centrally sensitized. And peripheral sensitization, the key is a diagnostic hot pack. If heat makes it worse, you got a peripheral problem. Maybe that's someone who you'd use iontophoresis with. I'm just trying to think what other modalities people use nowadays. I mean, I don't use the diathermy. That's just unrealistic. I mean, those are really, really the big things. Like, I'll occasionally use e-stim, and that's probably really the only warranted modality that I can even think of using, because I won't use ultrasound. There might be some evidence for shockwave therapy, but I don't really have access to that. I'm just trying to think of what other people have used that grinds my gears. Laser, you know, I believe that there is some research to support laser, but I'd never have access to it. So, and I don't even know when I would use it because the time thing. The time thing just continues to be a blockade for that, because I want to do things, if I'm going to do an intervention that's palliative or for symptom management, which a lot of modalities are, I'm going to do the fastest one that I can first and foremost, if it can't be achieved via exercise, because they can't take modalities home with them. They can't take manual therapy home with them, but they can take movement home with them. So if I can ameliorate symptoms with movement, I'm going to go with movement every day of the week, fam. So my company line on modalities, the decaf rule, peeps. I will only use e-stim if there's swelling involved, if I want to use it to help get a contraction of a muscle, and in the case of dry needling. That's really all I'd use, except one caveat, now that I think about it. So, when I was in the land of China, I had a phenomenal conversation with Michael Shacklock, which was mind-blowing to me because he is, you know, obviously you guys have probably seen the course notes that I have from his book, and he was a big influence for me, especially very early in my career. And to have just an unbelievable conversation with the guy over lunch, we talked for like 90 minutes, I think, was unreal. And then he came to my talk. It's like, damn. So very humbled in that regard. But he mentioned this time where he saw this patient, and the patient said, hey, you know, I got back pain or something along those lines, and you know, I've had this before, and you know, traction seemed to help, and you know, I did it in 4 visits, and it was fine. And guess what Shacklock did, right? Because we know the evidence is poor for traction, but he tractioned him. And I think in cases like that, modalities are probably warranted, because you know that this treatment has helped the individual in the past. Sure, there's a placebo effects involved, but there's placebo effects involved in all we do. And I think in that case, I would be very much inclined to utilize a modality, because if it worked for them in the past and they already have the perception that it's going to be helpful, why wouldn't you use it? You know it's going to be an easy slam dunk, and they probably want it. So move your ultrasound wand for 8 minutes. Don't even turn it on. You don't need to. Get them better. Get on with movement. And I think that'll be a good stopping point for tonight. Thank you guys so much for tuning in to today's movement debrief. Do you guys like the new time? If you don't, if you love it, if you hate it, let me know. The reason why I went with this is because of that whole daylight savings time. So in Arizona, we don't mess with daylight savings time because we are too cool for that. And so I'm always on Mountain Standard Time. You guys all shift if you observe daylight savings time. And so this is to account for that shift. But if you hate it, I can most certainly, okay, well, Gerard, I will keep it unless I'm in Arizona in the spring. In that case, it will be back at the old time. Sorry. Unless my work changes. Who knows? I mean, who knows what life's going to bring. We're going to stick with this for the foreseeable future. But, yeah. So we're gonna ride it out like this for a little while. If y'all hate it and you're like, Zach, why'd you ever do that, you jerk? Let me know. I'll be more than happy to change it, but I need enough people to say it. But I'll tell you what, if Gerard is already liking this, I'm inclined to keep it here for a little bit. So that's that. Where can you guys learn more? Glad you asked. First off, go to zachcouples.com. Sign up for my newsletter while you're there. Why? Because you can get free stuff. You can get free acute to chronic workload calculator. You can get access to the weekend learning goodies every Friday. You can get, this is coming up, and I'm probably going to record one of these this weekend, but you can get access to my talks. The talks that I did in China, I'm going to re-record them so we don't have to deal with the interpretation and you got to be there, instead of being there for 4 hours, you can be there for 2. It'll be for newsletter people only. Just saying, you probably should subscribe to it. So there's that. Also, while you're there, I offer services. What? Did you ask? I offer movement consultations. If you feel like a little toy, you're not moving as well as you'd like to. Maybe you've been to PT and it wasn't that effective, and you've gotten all the bad stuff cleared out. And you're wondering, Zach, what the hell's going on with me? Let's see if improving your movement helps. So go ahead and check me out there. It's on the service pages. I can help you out with that. Also, do you need a mentor? Do you need someone to help guide you through the clinical process or understand some of the concepts that I talk about a bit more in depth? Or maybe you just need someone to bounce ideas off of. I could be your guy. Go ahead and check me out on the services page. Sign up for the mentorship. Also, I offer online training. If you want to get back to getting jacked after rehab, if you want to lean out a little bit, if you want to improve your performance athletically, check me out. I do online training. Those are the services that I offer as of now. Maybe I'll offer some new stuff later. Who knows, man? It just depends on where I want to go with life. So there's that. In terms of the social media shindig, you can find me on Facebook. That's you guys right there. Facebook.com/ZCouples. I also have a page, Zach Couples PT. You might want to check that out. Once the numbers get big enough, I'm probably going to shift more towards that and then just do inappropriate things on my personal page. So maybe you want both. I don't know. Maybe you like inappropriate stuff. But go there. Yeah, Joe, I know you want the inappropriate stuff, girl. That's why you text me. So yes, go to Facebook, sign up for those things. And after that, then you probably want to go to that Instagram, baby. Search Zach, Z-A-C Couples, and you can find me on there. I post hiking pictures. I post a quote board. I do all types of stuff, fam. All types of stuff on Instagram. Go ahead and hit me up there. You can also find me on Twitter. My handle is @ZCouples. And the last place you can find me is on YouTube. That's you guys. Search Zach Couples or go youtube.com/user/couples-performance and you can find me there. Otherwise, that's probably all the places you can find me unless you want to come to Page America. You can do that too. We'll hang out, we'll go hiking or something like that. But otherwise, thank you guys so much for being a part of my life. I appreciate each and every one of you beautiful, sexy, outstanding people. I hope you guys keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces. And